the chip PCI most advances. I think the Professor Kasam cover everything, including chip PCI and imaging, so I can save some time. So as we know, chip including high-risk patient, high-risk lesion, and complex condition. So my topic may focus on the imaging-guided complex and high-risk patient in high-risk lesion. So from early 2018 to 2021, OCT and IRIS was recommended to guide the high-risk lesion, especially left main bifurcation and stent failure, and most recently, ENC guided update intracoronary imaging, including IRIS OCT, to recommended to guide complex lesion, particularly in left main bifurcation and true bifurcation and long lesion, especially in calcified lesion. And early 2013, the adapted DS compares the IRIS guidance and angio guidance in high-risk patient with MI, and IRIS guidance can reduce MACE up to 2 years, and recently the UpMate series trial directed led by Professor Chen up to 3 years. IRIS guided almost all comer patient can reduce 3 years target vascular failure, and recently IRIS was used to guide the ACS high-risk patient PCI, and also up to 1 year follow-up, and IRIS guidance can reduce target vascular failure. And Illumine trials from early Illumine 1, 2, 3, and recently Illumine 4 trials show similar message. Intravascular OCT or IRIS can reduce and improve the minimal stent area and improve the up to 2 years clinical outcomes. This Illumine 4 trial, although it's the main endpoint is negative, but still the surrogate endpoint OCT guidance PCI can improve the minimal lumen stent area, and especially can reduce the stent thrombosis. And high-risk lesion, including bifurcation, October trial published 2 years ago, and OCT guidance can reduce true bifurcation. 2 years outcome can reduce by 4%, so clinical outcome. And then some analysis, I think the last year in Europe is published, focused on left main bifurcation, very high risk lesion, and OCT guided. Actually, although number is small, about 100 patients in each group, I think it's underpowered to show the clinical outcome. Compare the angio guidance OCT didn't reduce the functional result assessed by FFR, but no different in terms of MACE compared to angio. And Renovate complex PCI focus on all complex lesions, including true bifurcation, CTO, and unprotected left main bifurcation, including over 1,600 patients per endpoint target vascular failure. And the result is very clear. Either IRIS or OCT guidance in complex PCI can reduce up to 3 years MACE, including the procedure-related mechanical function. And more recently, Occupy trial show focus on complex lesion use almost similar criteria to Illumine 4 trial, focus on stent dissection, stent expansion, and stent malabization, and up to 1 year follow-up, and compared to angio-only guided PCI, OCT guided PCI can reduce complete cardiac death, myocardial function, stent thrombosis, and target vascularization. I think all this take over all this data can show the message very clear in terms of chip PCI, including high-risk patient, especially high-risk lesion, intravascular imaging guided PCI compared to angio-only guided PCI can significantly reduce death, mechanical function, and stent thrombosis and see vascularization. I think the in current most recent guideline also show the intravascular imaging should be used in complex lesion. Very importantly, should use from very beginning and during procedure and after stent implantation to optimize your stent result. So I think another area is to show the high-risk lesion. Early in prospective study show the high-risk lesion, including a larger plaque burden and which I was defined TECFA and minimum lumen area, is very important to identify the high-risk lesion in high-risk patient. Patient carry this high-risk characteristic that has high risk future event. And Prescribed 2 followed by Prescribed 1 study used near iris to identify the plaque burden plus LCBI. That is a very good indicator of the high lipid burden. And the more high-risk characteristic carry the patient that had high-risk future event. So most recently, Pector's observed studies, multi-center observational study, so focused on a high-risk patient, MI with FFR negative non-corporate lesion. The presence of high-risk lesion is associated with worse clinical outcome. I think a similar message we show in the personal study. So how to treat those high-risk lesions? I think one of the most commonly applied is high-intensity stenting, including PCI. This is summarized 51 trial use intravascular imaging to look at the high-intensity lipid-lowering therapy. I think also the result is very consistent that high-intensity lipid-lowering therapy can reduce plaque volume, increase fiber cap thickness, and can stabilize the plaque and can reduce the plaque-related outcome. And also, Pacman MI, focus MI patient yellow trial also use near iris and OCT, and also most recently and more aggressively prospective absorb study use BVS and although his patient very small, less than 100 in age group, and target lesion failure is similar, but use BVS, I think long-term outcome is still very controversial. And more recently, PREVENT trial used DES or BVS to preventive treat the non-flow limiting high-risk plaque, identified either by iris OCT or nearest iris. Up to 7 years follow-up, and the result is very consistent. And preventive treatment, the high-risk plaque can reduce the non-comparative lesion-related event. So some specific intervention. More recently, roller coaster epical 22 trial compares 3 most common used strategy to modify severe calcification, including ROTA, laser, and IVL. And number is small, and by the result is IVL was non-inferior ROTA, but laser it didn't reach non-inferiority margin compared to ROTA. I think so. I think those 3 strategies compare the clinical outcome in this study is similar. So bifurcation already mentioned by Dr. Manson. I will skip. But this study most recently, I think the hybrid DCB strategy, the concept is to leave nothing behind, a simplified procedure and limited stent use. And the patient over 2,000, including 13 study, compares the 2-stent study, angioplasty, and hybrid DCB strategy. The overall, the result shows the hybrid strategy is better than the 2-stent strategy and angioplasty only in terms of composite endpoint, especially the target lesion vascularization. The TACTICS registry recent published is focused on ASAS patient, is run by 22 hospitals in Japan. The message is in terms of underlying mechanism, catchment nodule has worse outcome compared to plaque erosion and plaque rupture. So, ladies and gentlemen, take-home message is in terms of the chip PCI, I think the lesion assessment and guidance and center optimization is very important. So either IRIS or OCT compares the angles better in terms of reduce clinical outcome and improve the standard outcome. I think that in the future, more advanced hybrid imaging and model imaging will be used, and AI-assisted imaging will improve the clinical outcome of PCI. Thank you for your attention.